Step 3 during residency isn't impossible. However, cramming over 100 UWorld questions a day while working 80+ hours a week is. I took step 3 without doing a single practice question and scored in the top 5%. In this video, I'll show you exactly how I did it and how you can maximize your score in minimal time. Whether you just need to pass and move on with your life, or you need 250+ to strengthen your residency application. And stick around until the end to see whether you'll be ready to hit your step 3 goals or not. Let me tell you exactly what I did, and more importantly, what I didn't do, and how you can virtually guarantee a 250+ score on step 3. So I was an intern and I was working up to 80 hours a week, and honestly, sometimes probably more, as a transitional year intern at Newton Wolsey Hospital. And so I had surgery rotations, I had emergency medicine, I had internal medicine and ICU, and kind of the full gamut of things that you would be doing as an intern. Now, at the time, most residents around me were panicking about finding enough study time, since most of our studying prior to that for step 1 and step 2 had been dedicated study, meaning that we had time set aside where we could actually just sit down and make studying our sole focus. In residency, however, I realized that I wasn't going to have enough time. Instead, I needed a system that would work with the reality of just not having that much time. One of the most important things that I did is that I deliberately started taking public transportation to the hospital instead of driving. Now, granted, this ended up taking me much longer to get into the hospital, since to drive to the hospital maybe took 20 minutes, but to actually take public transportation, it was taking me up to 45 minutes every single day, both ways. Now, you would think that taking twice as long on my commute would have been a death knell for my studying. I was actually able to study while I was in the subway. And because of this, it gave me almost an hour every single day where I could do flashcards or do other kinds of study. I was also doing this while I had USMLE, and I had a blog growing on the side that was really taking off at this point during residency. And in addition to that, I had a coaching business and I had a young child. So this was the level of intentionality that I needed when I didn't have enough time, and the kind of thing that you can do in your life so that you can get more out of your time, even if you are a busy resident and working 80-hour weeks. Other things that I did included making flashcards immediately after seeing real patients, since I knew that I wasn't going to have enough time if I went home after a really long day in the hospital, and so I needed to make sure that I could do it at that moment. In addition to that, I would try to use every spare moment that was downtime. Instead of checking my email or phone or things like that, I was instead trying to make sure that I was doing small flashcards every single day, or other things that I could use that small bits of time effectively. The result is that I walked into step 3 without doing a single UWorld practice question and still ended up scoring in the top 5%. This wasn't luck, it was all based on a system. Next, I'm going to break down the exact 8 steps that made this possible, that can work whether you have 2 hours a day or just even 20 minutes. These strategies work whether you need to just pass or you're gunning for 250+ to get the highest score possible, so that you can buff up your applications if you need to reapply or anything like that. So let's get into it. Step number 1 is that you need to use your clinical judgment for you, not against you. Here's what nobody tells you. By the time that you take step 3, you've seen enough clinical scenarios that you could do many of these questions in your sleep if it was the actual clinical practice. However, that clinical practice can become your worst enemy if you're not careful. This is what they call the curse of knowledge. Now, when I was at Stanford, I did research for an entire year, plus several other months during my summer, during medical school, and then various other times throughout medical school. And when I was doing lung cancer research, I knew the literature, I knew trials, I knew lots of random edge cases. The result is that lung cancer actually became one of my worst sections on any sort of USMLE that I was taking. Now, why was this? It's because I knew way too much of the nuances, and I saw way too many atypical presentations, such that I was very good at picking out things that maybe didn't seem quite too right in the clinical scenarios themselves. This is a problem because tests are going to either test you on textbook answers for the most common scenarios, or they're going to give you relatively classic presentations, but also throw in some noise to try to confuse you. The issue is that if you're looking for the perfect scenario, or if you're basing your answers off of very particular clinical expertise, you can sometimes get yourself way off track. So the solution to this is that you don't want to be the lawyer, and instead you want to be the judge. Now, what do I mean by this? Lawyers are looking for any flaw to throw out evidence, whereas judges are weighing evidence fairly. So what does this mean in practice? A lawyer will see one detail that doesn't fit perfectly, and they're gonna say, I don't know, I don't think that this makes sense. So in my case for lung cancer, I would see something that didn't quite look perfect. Like I remember looking at one slide of small cell lung cancer, which is what I was doing research on, and saying, I don't know, the nuclear to cytoplasmic ratio doesn't quite look right. This doesn't quite look like small cell lung cancer, and I eliminated it. That was dumb because very clearly it wasn't the one that I chose, but because I eliminated small cell lung cancer, I was forced to choose among the other answer choices. Note that this gets worse if you're already struggling or if you're under time pressure. Another thing to realize is that step 3 has intentional noise, which means that not everything is going to fit perfectly. And so it's really easy, the more that you know, like if you have a lot of clinical experience, a la being a resident, it's very easy to see that noise and think, oh wow, this doesn't fit, this must not be the right answer, and then eliminate it and then struggle because now you have to choose among answers that are even less correct. So how do we fix this? You want to be the judge, which means you want to weigh each piece of evidence proportionally. In other words, you want to say, why would this make sense? And why wouldn't this make sense? In particular, don't let one small inconsistency override 3 major findings that are pointing to an obvious diagnosis. There was a student that I was coaching once, and she wanted to go into pediatrics. She had gotten a question wrong on Klinefelter syndrome, right, which is a pediatric condition, and she was like, oh man, I knew it was Klinefelter's because everything was classic about it, except they were adolescent and they weren't tall. And it just didn't quite make sense to me because I knew Klinefelter patients, I don't know, classically they're tall. And because this one thing didn't fit, she went into lawyer mode. And as a consequence, she eliminated it. She should have said, okay, well, this amount of evidence doesn't support this alternative diagnosis, and maybe this one might support it because in this condition, they're not tall. So let's go with the one where more of it makes sense and compare them side by side, as opposed to just eliminating one answer that I was thinking about and then choosing the remaining answer. Now that you know how to use your experience correctly, let's address the elephant in the room. Step 2. Stop complaining about time and instead optimize for efficiency. When you're a resident, you don't have enough time. I get it. But saying, I don't have enough time strips away your power. Instead, you want to ask, how can I be more efficient with the time that I do have? Let's be honest, this is probably the least amount of time that you will ever have to study in your entire life. You've got 60 to 80 hour work weeks, let alone possibly having kids or other family obligations. Now, while you can't control your hospital hours, you can control your efficiency. So instead of giving up our power and saying, oh, well, I don't have enough time, that's the reason why I'm not able to study, instead say, how can I be more efficient? And when we think about efficiency, we want to reverse engineer what really matters. Every test, including step 3, fundamentally needs 3 things that you need to master in order to do really well. The first is that you have to learn things well, ideally using principles, not just memorizing facts. Second, you need to make sure that you never forget them, which ideally you're going to use something like spaced repetition. And then third, you want to apply them systematically. In other words, you want to have a question interpretation framework. All of these things we're going to cover more, but these are the principles that we're going to start with. The crux of this is that if you're not doing all 3 of these efficiently, you're wasting time. And as a resident, you cannot afford to waste time. So what does efficiency actually look like? Now, you can do things like make flashcards during downtime, so before rounds, lunch breaks, or on your commute, like I was when I was a resident. You can also learn from every patient that you see. Remember, your patient care can be your studying as long as you approach it in the right way. If you learn a principle and then you use that to apply it to your patient care, you can actually reinforce what it is that you're learning, and you'll be able to remember it much better since you're going to tie it to real clinical scenarios. One well-made flashcard from a real patient that you saw is worth 10 random UWorld questions that you are barely going to review afterwards. In addition, study in 5 to 10 minute chunks instead of waiting for that 2-hour block that's never going to come. I used to try to wait for like the perfect time to study and instead realized I just needed to make do with whatever it is that I had. So if I had a couple minutes, I would use those couple minutes. And if I had 10 minutes, I would use those 10 minutes instead of hoping that I could find that 1-hour chunk of time that really just never was coming. To be efficient, you need to know what to learn, and that starts with understanding principles. This brings us to step 3, master management, which is really just diagnosis plus severity. One of the hardest things is remembering all of the management algorithms for conditions that you studied maybe years ago in medical school. But there is an easier way of doing this. If you're memorizing management algorithms for every condition, you are doing it wrong. Instead, almost every step 3 management question, which can make up to 50% of the test, needs just 2 things: diagnosis and severity. This gets back to learning things from a principle-based standpoint. So this is a management principle. The management principle, very simply, is the more severe the presentation, the more invasive or the more urgent the intervention. The less severe the presentation, the more conservative the management's going to be. Literally, this will help you on 80% or more of your management questions. You won't need to memorize every single specific algorithm, especially for those things that you don't see in your everyday life. I coached a student from Harvard once who was going to Harvard Medical School, and he had gone to Princeton for undergrad. Someone who was just brilliant, like absolutely brilliant. But he struggled a lot with management questions. And one of the things that he was doing was that he was just trying to memorize all of the different clues. And so I remember distinctly, he came to me once, we were sitting in one of the lounges in MGH, and he came to me and he said, this management question here was about diverticulitis. And the answer was IV fluids and IV antibiotics. And this answer here was that I had to go to surgery. I don't understand. They were both acute diverticulitis questions. Why is it in this case I was giving them IV antibiotics, and in this case I was taking them to surgery? What he was missing was the severity clues. Clues that something is more severe are the location first, right? So if you're in the emergency department, or especially if you were brought to the emergency department, that implies that this is much more severe, as opposed to things like annual physical, which implies that the problem is probably minimally symptomatic or asymptomatic, or things like a pre-participation sports physical for something like pediatrics, or the random health fair that you'll see sometimes, which also implies a very low severity. Another sign of severity is looking at the vital signs. So if the heart rate is ever above the systolic blood pressure, that is a pretty clear sign of shock. And that is telling you again that this is going to be more severe. Whereas if the heart rate is normal and the blood pressure is normal, that is telling you that it's less severe. A really common one that got me when I was a medical student was organ dysfunction signs. So for example, I didn't really understand, why are they telling me that this patient is disoriented, right? Really what they were saying is that they had altered mental status because there was a decrease in functioning of the cerebral cortex, right? So maybe there was too little oxygen, right, that was getting to the brain, or there was too little blood. Whatever it was, there was a dysfunction of the end organ. The same thing with low urine output, same thing with things like lightheadedness or decreased capillary refill or things like that. A final clue for severity is acuity, where things that are more acute oftentimes are going to be more severe since they're presenting or they're progressing much more quickly, as opposed to things that have a more chronic or indolent presentation. So how can we use these severity clues to help us to get more management questions correct for less time invested? So for example, let's look at a patient who's in shock who has a suspected DVT. In this case, because it's more severe, right, because the patient is in shock, you'd want to do something more invasive, like say therapeutic anticoagulation, or if it's really, really bad, then, maybe something like TPA. But let's say that you've got an asymptomatic patient with a more incidental finding. You would want to do the less invasive option, right? Something like observation or reassurance, or some sort of outpatient workup. If the patient's lost consciousness or is in shock, you're not going to do something conservative. So why does this save you time? You're going to be able to leverage clinical experience since you have seen the severity in real life. What this means is that you don't need to memorize every single specific next step. And what this does is it reduces your cognitive load dramatically so that you can get many, many more questions correct with much more confidence with much less time invested. Understanding severity is critical, but you also need to read questions systematically to catch what test writers actually want. This brings us to step 4, the context chronology severity framework. Up to 50% of missed questions have nothing to do with knowledge gaps. We miss them instead because we don't understand what test writers want. This framework fixes that. Let me show you how to do this with one example. Let's say you've got a 25-year-old woman who comes to the ED with 2 hours of chest pain and shortness of breath. She was on a transcontinental flight 5 days ago, and she started oral contraceptive pills 2 months ago. Her vitals show that she has a heart rate of 110, her blood pressure is 118/75, and her oxygen saturation is 92%. Now let's use the context chronology framework to understand this vignette. Context means that we have to understand everything in the context of the vignette, not just seeing every piece by itself. So in our example, the patient has chest pain. Now, chest pain in and of itself is very nonspecific. This could be anything. Could be an MI, could be a PE, could be pneumonia, anxiety, something MSK related. We don't know from just chest pain what this is going to be. In addition, she had a recent flight. So if I was just searching for buzzwords, which is what a lot of people do, they're just kind of scanning and hoping that they see something that sparks their differential diagnosis. A recent flight may or may not tell me anything useful. Maybe it could be jet lag. Maybe there could be some kind of travel fatigue. And then taking OCPs doesn't necessarily say a lot. That could just be noise because lots of women take them. And in addition to that, tachycardia and hypoxemia have many potential causes. However, when we connect all of these things together, OCPs, is a potential hypercoagulability risk. Flight is prolonged immobility, which again increases the risk of something like a DVT. And then in that context, acute chest pain and shortness of breath plus hypoxemia plus tachycardia suggests something like a PE. The key thing is that any one of those symptoms by itself is not pathognomonic, meaning each one of those symptoms needs to be taken in the context of others. So if you want to get more questions correct without having to study longer, don't scan for buzzwords. Instead, ask, how does this connect to what I've already seen in the vignette? Each piece individually doesn't tell you much, but all the pieces together makes PE become relatively obvious. Next in our context chronology severity framework is chronology, where we reorder the timeline. The way that they write questions is the same way that we present it in clinical practice, which means it's scrambled in terms of the actual chronologic order. There was a professor at Stanford when I was a medical student who would always make the residents and medical students rearrange things chronologically so that you could see the relationship between the different elements. But let's look at the actual elements in the way that it was presented first so that we can see how useful it is to rearrange it. In this case, the patient comes to the ED with 2 hours of symptoms. She had a flight 5 days ago and she started OCPs 2 months ago. Now, could you figure it out from just those clues? Yeah, you could. However, let's look at what happens if we actually rearrange it in the chronological order in which it happened. The way I like to do this is to pretend that the patient is in the present tense throughout the entire story. So let's say we've got a 25-year-old woman who starts taking oral contraceptive pills. Then roughly 2 months later, she gets on a transcontinental flight, which gives her immobility and the hypercoagulability with the OCPs. And then 5 days after that, she has chest pain, hypoxemia, and tachycardia. When I rearrange it in this order, now it becomes a lot more obvious what the pathophysiology is. Here, we've got a hypercoagulable woman who has an immobility event and then has signs of a PE. If you're getting questions wrong that you have all the knowledge for and where you look back and you're like, how did I miss that? One of the most common reasons is that you're not rearranging it chronologically. And if you're still missing questions that you should be getting correct, severity can save your bacon. So severity means how urgent is this? As we talked about before, things like location, end organ dysfunction, vitals, and acuity can tell you a lot about the severity of a condition. As you're reading the question, these severity clues typically are going to match with each other, right? So someone who is brought to the emergency department is going to have either signs of end organ dysfunction and or pretty severe vitals, so like shock vitals. And as we discussed, this is critical since so many questions on Step 3 depend on your ability to do management questions. And so the more severe the presentation, the more invasive or the more urgent the intervention, and the less severe the presentation, the less urgent or the less invasive the management is going to be. Now you've mastered reading the vignette, but here's where residents make their biggest mistake. They look at answer choices too early and get confused. Let me show you how to answer the question before you see the choices. For this, we'll use a related venothromboembolism scenario. This brings us to Step 5, create a standalone question. Want to instantly boost your score? Stop looking at answer choices too early. Remember, they're designed to confuse you. Let me show you another case with a venous thromboembolism. We've got a 62-year-old woman on postoperative day 2 after a total knee replacement. She develops unilateral left leg pain and swelling. Ultrasound confirms a deep vein thrombosis, and she's currently receiving prophylactic subcutaneous heparin, 5,000 units twice daily. Her vital signs are stable. And the question is something like, what is the most appropriate next step in management for this patient? So I'll tell you what I used to do, and that led me to get tons of extra questions wrong that were unnecessary. And then I'll explain what it is that you should do instead to get more questions correct for the limited amount of time that you have as residents. What most people do when they get to the question is they read it very quickly and then they immediately look at the answer choices and hope that one of the answers stands out to them. The student would immediately look and see something like, okay, well, A is continue current prophylactic heparin dose, B is initiate therapeutic intravenous heparin or enoxaparin, C is place an IVC filter, and D is apply compression stocking. The problem with that is that they're already thinking in their head of trying to justify why maybe this answer might make sense. And plus, if I've already been struggling on my exams, this tendency becomes much stronger, where we start to doubt ourselves and say, oh, I don't know, this kind of like maybe could make sense. And we kind of talk ourselves into an answer choice as opposed to really being confident with it. So for A, the continue prophylactic heparin, you might kind of twist it into like, I don't know, she's already on heparin, so I don't know, maybe I should continue it. And for C, you might say something like, well, I know that an IVC filter can prevent a PE, so I don't know, that kind of sounds good. Remember, all of these answer choices are there because they are the right answer for certain scenarios. If you read the test writer's guide for the USMLEs, for the National Board of Medical Examiners, which writes the USMLE Step 1, Step 2, Step 3, and shelf exams, they actually publish their rule book for writing questions. And one of the rules is basically that if not enough people choose an alternative answer choice, like one of the wrong answers, then they know that it's not a great answer choice, and so they will eliminate it. All of the answer choices make sense on a certain level. The problem comes when we're looking at answer choices before we commit to them, which makes us play matchmaking games instead of actually using our clinical reasoning. The right approach is instead to create a standalone question first. If you've been following up until this point, you know that when you read the vignette, you want to follow the context, chronology, severity framework. Here's a woman who had surgery. She got prophylactic heparin, but despite the prophylactic heparin, now she's developed DVT, and so now she needs treatment. From a severity standpoint, she's relatively stable, so it's sort of mild to moderate in the sense that it's a real DVT, we need to treat it, but she's not in extremis, she's not, having horrible shock vitals or things like that, and she doesn't have clear signs of end organ dysfunction. Next, you want to cover the answers, which actually they recommend in the test writer's guide. They call it the cover the responses rule. The room of experts should be able to unanimously agree on what the answer is without knowing what the answer choices are. And the way that we do this is that we create our standalone question. So what is a standalone question? I like to call this a standalone question because it should stand alone. Meaning, if I came up to you on the street and I asked you the question, you should be able to answer it without knowing anything about the vignette and without knowing anything about the actual answer choices themselves. So I'll give you an example of a bad standalone question. A bad standalone question has too many details, like what is the management for a DVT in a post-op patient on prophylactic heparin? While technically true, is way too specific. And the reason why this is a problem is that when you ask a question like that, it's going to induce panic much of the time, right? If you ever find yourself wondering like, God, I don't remember that exact algorithm. Oh my gosh, I don't know exactly what the management would be in the scenario. You're probably asking a standalone question that's too detailed. Instead, a good standalone question is going to use principles. You want to ask yourself first, what am I really being tested on? Is the key that this person is post-op day 2 from a hip replacement and she's on BID prophylactic heparin and now has a DVT? That seems pretty specific, right? Or are they just asking me, how do I treat an acute DVT? Or are they just testing my ability to differentiate between treatment of a DVT versus prophylaxis? So my standalone question could be something like, what do I do when prophylaxis has failed and the patient now has a confirmed clot? Or frankly, an even simpler one would be, what is the treatment for acute DVT? Or what is the treatment for a mild to moderate DVT, right? Taking into account the fact that if it was more severe, I'm going to do something much more invasive. And because it's less severe, I'm going to do something that is less invasive, right? I'm not going to be doing TPA or something like that. The next step is that you want to answer your own question before you look at the answer choices. Again, remember the cover the responses rule. So I'd probably be thinking to myself, okay, well, prophylaxis didn't work. I need to escalate to actual treatment, but it's not like super severe. So I'm probably not going to do the most invasive option. Finally, we want to find the correct answer choice based off of our standalone question. So A is to continue prophylaxis. That doesn't really make sense since it failed before, and this has to be something that's more aggressive than just the prophylactic dose. B, therapeutic heparin and enoxaparin. Yeah, that actually would make sense. So that would have fit the answer that I was thinking in my head. And C, IVC filter. No, that is going to be second line if anticoagulation were contraindicated or we've tried therapeutic anticoagulation and it didn't work. And then finally, compression stockings wouldn't make sense because this is more of the prevention and supportive category as opposed to the actual treatment itself. So the answer would be B. Remember, to get a good standalone question, if someone asks just the question stem, meaning no vignette, no answer choices, could you answer it clearly? If you can, great. Now you know what it is that you're looking for. But here's where residents often sabotage themselves. Let's look at the answer choices more carefully, and I'll show you why your first instinct is probably wrong and what you can do to dramatically increase your score despite not having a lot of time to study. This brings us to step number 6. Rule in before you rule out. Our brains naturally want to eliminate choices. The problem is that this instinct is going to cost you points. So let me show you what happens with this same DVT patient that we just talked about. So we had a 62-year-old female, post-op day 2, confirmed DVT on prophylactic heparin, 5,000 units, sub-Q, BID. We created a standalone question, and now we know that we need to get therapeutic anticoagulation for acute DVT. Here are the choices. A, continue current prophylactic heparin dose. B, initiate therapeutic intravenous heparin or enoxaparin. C, place an IVC filter. D, apply compression stockings. Or E, warfarin therapy alone. What most step 3 takers do is they're going to eliminate answers. They're going to find reasons why the particular answer is not correct. Let's say that we were looking at B. What happened when the student that I was working with is she saw therapeutic heparin and she's like, well, wait a minute, she's already on heparin. More heparin, this is like doubling up. Now this must be dangerous. Okay, no, this must not be the correct answer. Think for yourself. How many times have you eliminated an answer choice that ended up being the correct answer? If you think back to what you did in that situation, what usually we find is that people will try to figure out reasons why they shouldn't choose the answer first, and they go with that as their instinct. And then only after they've eliminated the best answer, then they're kind of stuck and like, oh, I don't know, I'm not really sure what's going on. And then they just kind of choose something random. But the issue is that once we eliminate the correct answer, then we're going to look at something else and be like, okay, well, C is IVC filter. Well, IVC filter, it does catch clots before they reach the lung, so it would seem logical. So I don't know, maybe C. The problem is that, like we talked about before, they were the lawyer and not the judge. So they were the lawyer in the sense that there was one thing that didn't quite fit what their perfect idea was in their mind, and so they eliminated it because it felt uncomfortable. And then they were the lawyer then for the incorrect answer in that they tried to justify why that answer might be correct. That's one of the most common reasons why people will score well below what their clinical knowledge actually would imply. The problem being that they eliminated the correct answer without thinking about what it actually meant and assumed that, okay, well, they're already on heparin, and so more heparin must be bad based on sort of surface level reasoning or based off of their sort of quick intuition-based thinking. The right approach is to rule it in before you rule it out. What does that mean? That means that for every answer choice, first ask, why would this be correct? Or in what scenario would this be correct? And then ask yourself, why does this not make sense? This is the correct answer to prevent DVT, right? This is right for one answer, right? For some scenarios, those scenarios being if I wanted to prevent DVT, right? However, the rule out is that this doesn't make sense because this person already has the DVT, and so prophylactic heparin, just using the mini dose, is not going to be enough to actually treat it. And then we get to B, therapeutic IV heparin or enoxaparin. This would be the correct answer for someone who has a DVT or a PE. Now that I've identified that actually makes sense. This actually could be the right answer. And so then I would go to rule it out and say, well, okay, why would this not make sense? Okay, well, let's think about heparin. She's on prophylactic heparin currently. Oh, I get it, right? And so because I've already ruled it in, I've already identified, okay, well, this is why this would be the correct answer. It's a lot easier for me to then realize the fault of my sort of intuitive reasoning, which is like, okay, well, she's on heparin. I don't want to give more heparin, right? It's that, oh no, this is actually the prophylactic heparin, and now she was previously on the prophylactic heparin, and so now we need to actually treat her. So for IVC filter, what would this be the correct answer for? Well, IVC filters are used for patients for whom they can't take anticoagulation or anticoagulation hasn't worked. So that would be the reason why we would use an IVC filter. The rule out is, okay, well, why would this not make sense in this case? This wouldn't make sense because it's really a second line therapy. It's only used when anticoagulation has failed or is contraindicated. And in this case, neither of those things is true. Therefore, it really doesn't make sense for this particular scenario. Notice how we've avoided the common trap of trying to pick out as the lawyer one little reason why this thing doesn't make sense, why B didn't make sense, and eliminate it, and then try to justify why C would make sense. Instead, we got into the test writer's mind and asked, okay, well, what would this be the correct answer for? And does this match this particular scenario? And then ask ourselves, okay, well, what would rule this out for all of the different answer choices? This is a fantastic catch-all for lots of kinds of mistakes that you might have. So if, for example, you didn't understand the standalone question correctly, this can be really useful. For diagnosis questions, this can be extremely helpful because it will force you to say, okay, well, this is the kind of presentation that would fit with this particular answer choice. So let's go back and look, does this make sense based on the presentation given in the vignette? And so you can tell pretty quickly, oh, okay, actually, no, this actually would fit as the diagnosis. Ruling in before you rule out is a really good way in general to catch yourself on those silly mistakes that we make that cause our scores to be a lot lower than our knowledge really would imply. And these frameworks work, but only if you never forget what it is that you learned in the first place. So next, let me show you the system that compounds knowledge without massive time investment. This brings us to step number 7, build your never forget system. I can't tell you how many residents or medical students I've heard say, I hate Anki, or I'm not an Anki person. It's true, Anki can completely suck. It is one of the most miserable forms of studying that I've ever found. However, the real question is, what's more painful? Learning a system that compounds your knowledge over time, even if you've only got 20 or 30 minutes a day to study, or having to constantly relearn everything that you've forgotten when you are really busy on rotations and have all these other life responsibilities. The reason why Anki is a non-negotiable for residents who want to pass their step 3 or get the highest score possible is that if you never ever forget what it is that you learn, knowledge accumulates remarkably fast. If you have limited study time, you cannot afford to relearn things. This is especially critical for specialties that you're not currently doing rotations through. So if you are an OB resident, or if you're a peds resident and you're not doing internal medicine, this is really, really valuable because you don't want to forget all the things that you've already learned. Or if you've got to go and relearn some of these things, you don't want to have to go back and constantly relearn these things, especially if it's not that relevant to your day-to-day. This is ultimately how I scored in the top 5% on step 3, despite the fact that I had no dedicated study time. I just literally went in and took the test, and I didn't do any sort of questions or prep beforehand. Obviously, if you've made cards before during your step 1 or step 2 or shelf prep, it makes it a lot easier. However, even if you haven't done that, you can still start from scratch, even if you've never made flashcards in your life. The first thing that you need to do to make this work for step 3 is that you want to make cards from real patients, particularly if there's a framework or something that you learned from a particular patient. Like, for example, there was a patient that we had in the emergency department. The patient was really short of breath. And I remember that there was an ICU attending who told me his sort of way of thinking, okay, do I intubate someone or not? Or do I do, BiPAP or whatever? And so I took that algorithm that he used with that patient still in my mind, and I made a card that helped me to remember, oh, okay, when should you intubate someone or when should you not intubate someone practically based on what it is that you see when you're in the patient's room. The second kind of card that you want to make is a principle-based card, not just fact-based cards. Before, when we talked about how do you answer a management question, that's a really good principle, because in general, the more severe the presentation, the more likely it is that you're going to do something invasive and or urgent. Whereas the less severe the presentation, the more likely it is that you're going to do something that is less urgent or less invasive. The third thing is that you want to do your cards in micro moments. It is rare that you're going to have an hour free to do whatever it is that you want, and especially to study. So instead, what you need to do is take advantage of those 1 or 2 or 3 minute chunks that you have throughout your day in order to do your flashcards. In general, what I have found is that for people that try to do practice questions when they are doing hospital work, it almost never works, because to do a practice question well, you need several minutes at a time of uninterrupted focus in order to do that question. And that's just one question, let alone like a 5 or 10 question block. Instead, a 30-second break can be great to do 1 or even 2 cards. And when you add up all of those breaks throughout the day, it can be fantastic, especially if you want to do your cards during your lunch break or during commute time like I did, or if I'm honest, sometimes during noon conference or things like that. And remember, I'm not saying that this is going to be easy. It's actually really hard to do cards, and especially to make cards, especially if you've never made cards ever in your life. But remember that the alternative is that you are going to forget most of what it is that you learn and have to go back and relearn it. The path is going to be painful. It's just you've got to decide, do you want to take the path of pain that's going to lead to long-term accumulation of knowledge that's going to help you not just for your step 3, but also your future exams like in-training exams and board exams? Or do you want to take the path where you're going to forget stuff and you're going to have the pain of constantly having to go back and relearn it? And I know this system works, but how do you start when you're overwhelmed and exhausted? This brings us to step number 8, just start small. The 1 push-up rule. The biggest barrier to step 3 success isn't lack of knowledge. Instead, it's perfectionism and an all or nothing thinking. You're waiting for a perfect 2-hour study block that will never, ever happen. One of the most common reasons why I procrastinate, and many people I know procrastinate, is that there's this big gap between our ambitions, like I want to get 40 questions done today, and our reality, which is that we're maybe exhausted after a 12-hour shift or an overnight 24-hour call. This gap between our desired results and our actual state creates anxiety. And this triggers procrastination, which creates more anxiety, which then feeds back into more and more procrastination, right? Because procrastination is ultimately just the fight or flight instinct. We respond to psychological threats in the same way that we respond to physical threats, meaning that if I've got 40 questions that I feel like I need to do in order to catch up on all the work that I haven't done previously, that's going to trigger the same kind of fight or flight response as a lion charging at me. And so the flight in this case isn't physically running away from a lion, it's actually just avoiding sitting down and doing the questions. And so instead of doing 40 questions, I might do 0. This perfectionism of I need to find the perfect study block can get in the way of even the best of us. So what do? Enter the 1 push-up rule. The thing to ask yourself is, what's the smallest version of this that I could do right now? Granted, I might not have time for those 40 questions, but I will have time for just one. One question done properly is infinitely better than trying to do 10 that you never ever attempt. And honestly, the hardest part is getting started. What you'll find, and this is why my father-in-law calls it the 1 push-up rule, is that if you want to do 40 push-ups, don't say you're gonna do 40 push-ups. Instead, just say, I'm gonna do 1 push-up. Because if I do 1 push-up, because starting is the hardest thing, I'm never gonna stop at just 1 push-up. Instead, I'm probably gonna keep going, and I'll do many more push-ups than if I'd started with the idea of doing 40. Remember, this isn't about daily volume. Instead, it's about momentum. I did my 2 questions today. It feels infinitely better than I didn't study again. And because the momentum tends to build, usually if you say I did 2 questions, it's rare that you're gonna stop at 2. You're probably gonna end up doing more. But even if you just did 2, that's infinitely better than not studying for many, many days in a row and just hoping that you're gonna make up for it with that magic 2-hour or 4-hour study block that you're gonna have later. That just, never really materializes. Plus, as you make and do Anki, your knowledge is going to compound and you'll be shocked at how much you can gain over a long period of time. I had a conversation recently with a dean at a DO medical school, and we were talking about a student who had come to us who had failed level 1 twice. And in one of those years, she had spent a year kind of studying just, because she'd had to take a year off because she needed to take care of a sick parent. Both the student and the dean were like, she's already studied for a year. Why would she spend any more time? She should have had enough time to do this. If you learn 5 things every day and you forget 5 things every day, then you could study for 1,000,000 years and your knowledge will still be stuck at the same level. However, if you do the 1 push-up rule and you combine that with a system of making cards based off of the things that you learn and you never, ever, ever forget it, even if you only learned 1 thing every day and you just never forgot it, you would find that as you stack the number of days in training, you would accumulate a massive amount of knowledge over time. All right, so now let me address the most common questions that I get about step 3 preparation. So the first question is, how do I handle CCS cases with minimal practice? I'll be honest, I didn't do a ton of CCS cases. I had this idea that I was gonna do the entire CCS QBank, and I had this grand notion of doing a bunch of things to study, but I honestly didn't really get around to it much. What I did find though is that there was a massive difference between not doing CCS cases and doing like the first 5 or 10. And so if you find yourself really, really busy, in an ideal world, obviously, the more that you can study for these, study both CCS and the multiple choice questions, the better. However, if you're like most residents studying for step 3, or if you're studying for step 3 and you're doing research or something else, just learning the format of CCS is honestly, in my opinion, one of the most valuable things to do. And so you can learn that probably within, I think I did maybe 10 questions on the CCS, or maybe 15, something like that. I would recommend that you do some, but you don't have to do like the entire QBank. Again, don't let perfect be the enemy of good in this case. The second question is, what if I'm in a non-clinical specialty like radiology, pathology, or anesthesia? This is a great question. This is one thing that I kind of struggled with because I was an anesthesia resident. One piece of advice that I heard when I began intern year was that, especially if the field that you are going to be doing for residency is very different from, say, internal medicine, or more broadly what it is that's on step 3, is that you should try to take your test as soon as possible. I think in general that's probably true. The only caveat would be that if it's something like radiology or anesthesiology, if you're in a transitional year, or if you're in a prelim year where you are exposed to a lot of the different specialties, like especially the internal medicine based specialties, because most of step 3 is still going to be internal medicine, just like most of step 2 was internal medicine. What you're doing every day is learning a little bit and using Anki so that you never ever forget it, so that you can accumulate that knowledge over time. It would be okay to take your test sort of later on in the year. If you're not going to do that, or if you know yourself and you know that it's going to be harder to do something like Anki, then probably try to plan on taking it sooner on in the year, rather than waiting until you've forgotten more of the information. The third question is, how many UWorld questions do I actually need to do? I personally recommend, in general, doing quality over quantity. Obviously, there is a correlation between the number of UWorld questions that someone does and their final score. What I've never seen clearly is a causal relationship where, you told two groups of people, hey, this group should do more questions and hey, this group should do fewer questions, and they actually followed that, and the group that did more questions did better. I'm not entirely sure that that is the result that we would see. And the reason for that is that the students that are best prepared for taking UWorld questions in the first place are also the ones that are going to be able to do the most questions, right? So for example, I came into my step 1 and my step 2 dedicated periods knowing a lot of material. And so I was able to I actually didn't study that much for step 2, but for step 1, I studied a lot. And so I was doing maybe 100 questions a day. But it was because I had made Anki cards for so long and I hadn't forgotten that information. And so of course I was able to get through more than 100 questions in a day because I didn't have a lot of things that I needed to relearn because I could remember most of the material. So instead of focusing on the number of questions, instead I would focus on the questions that you learn, make sure that you learn it really well, and make sure that you learn all of the related topics for that extremely well so that you can get that and any other related questions correct on that topic in the future. But that would be what I would recommend. What about topics I haven't seen in months, like OB or peds? If say I'm a medicine resident, if I'm an OB resident, like what would I do for internal medicine? What I recommend is to do questions first, and then based on those questions in that topic, study with something like first aid to cover the entire topic. Again, I've got more on this later, but the general idea is that you don't have enough time on any given day to learn everything about everything. And so what most people do is they just try to cram as many questions as possible and just hope that through exposure that they're able to get their scores up. Especially if you're kind of in the borderline passing range, oftentimes there is a significant number of knowledge gaps. And so you want to figure out how can I fix at least one significant knowledge gap per day of studying. And so for example, let's say that I am an OB resident and I very rarely see patients that have coronary artery disease. What I would do is I would try to learn all of the coronary artery disease related information in first aid first, put that into Anki. I would try to make sure that I did those cards so that I continued to do those cards so that I could keep that information in my brain on an ongoing basis. So let's bring this all together. To virtually guarantee a 250 plus in step 3 while working as a resident, you need first, use clinical experience correctly. So you want to be the judge, not the lawyer. Second, optimize for efficiency. You can't control your time, but you can control your efficiency. Third, master principles. So for example, for management questions, remember that if you know the diagnosis and you know the severity, you can eliminate most, if not all of the incorrect answers just based off of those two things. Fourth, use a systematic question reading system. In our case, we recommend the context, chronology, severity framework so that you can understand what's in the brain of the test writer. Fifth, create standalone questions. It should be a question that I could come up to you on the street and ask you that question without giving you anything about the vignette or anything about the answer choices, and you should be able to answer it without knowing either of those things. And ideally, it's something that focuses on the principles and doesn't just get kind of lost in the details. Sixth is you want to rule in first before you try to rule out. Because remember, our brains will naturally try to find all of the flaws in the answer choices. And so instead you want to rule it in and figure out what is this the correct answer for first before you try to rule it out. 7, create a never forget system, which in the case of a resident is going to be using spaced repetition so that you never forget the things that you're learning, especially when you can try to use real cases to illustrate principles. And then 8, start small. Use the 1 push-up rule to build momentum. If you find this helpful, be sure to check out our 14-day mini course. In the description, you'll find a link. You'll find more lessons on how to get more out of your time so that you can get the highest possible step 3 score despite being a really busy intern or resident. And one more thing, if you're wondering how to actually implement all of this with UWorld, how many questions, timed or untimed, mixed or by topic, check out my UWorld Complete Guide, 5 levels of mastery to 260 plus. I break down the exact progression from 5 question untimed blocks to 40 question mixed time sessions with the specific metrics that make success inevitable at every stage.